Hello and welcome to this cardiology module where we will be discussing cardiorespiratory arrest. By the end of this module, you should be able to define what is cardiorespiratory arrest, outline the causes of cardiorespiratory arrest, which are the 5H and 5Ts. You should also be able to outline and recall the algorithm of the advanced cardiac life support. Let's jump straight into it. So what are the reversible causes of cardiorespiratory arrest? There are 5H, which are hypoxia, hypovolemia, hypothermia, hypo or hyperkalemia, and hydrogen ion buildup causing acidosis. And the 5Ts, which are tension pneumothorax, tamponade, pulmonary thrombosis, coronary thrombosis, and toxins. Let's look at the first H, which is hypoxia. Hypoxia means deficiency in the amount of oxygen reaching the tissues. Causes of hypoxia include low oxygen concentration in the surrounding atmosphere. So hypoxia can occur in high altitudes due to the lower oxygen concentration in a lower atmospheric pressure level. Atmospheric pressure decreases exponentially with the altitude, while the oxygen fraction remains constant to about 100 kilometers. Oxygen saturation decreases exponentially with altitude as well. The manifestations range from mild symptoms to fatal-like conditions such as seen in high-altitude pulmonary edema and high-altitude cerebral edema. Next cause of hypoxia is the failure of oxygen flow into the airway. This can happen in airway obstruction. Airway obstruction can occur in edema of soft tissues of the upper airway tract, laryngospasm, aspiration, asphyxiation, which occurs in hanging and drowning. And asthma is a form of immune-mediated inflammatory reaction of the lower respiratory tract leading to obstruction of the smaller airways. Chronic obstructive pulmonary disease such as emphysema or chronic bronchitis, which is exacerbated, can present with hypoxia due to the reduced compliance of the smaller airways. Next, restriction of ventilatory effort to drive oxygen into the airway that can lead to hypoxia. Central hypoventilation happens when respiratory control in the brain is compromised by brain herniation or drugs. Another form of hypoventilation occurs in restrictive lung diseases, when there is impaired alveolar ventilation from neuromuscular diseases and chest wall deformities. Ventilation diffusion defects at the alveoli and blood membrane. Another stage where hypoxia can occur is at the level of gaseous exchange, which is at the alveoli. Pneumonia leads to inflammatory fluid buildup in the alveoli, which in turn then leads to poor ventilation and diffusion of gases in the lungs. Another example of this situation is pulmonary edema. Finally, reduced red blood cells carrying hemoglobin, and this condition is referred to as anemia. This can also lead to hypoxia because as the number of red blood cells containing hemoglobin is severely reduced, the oxygen carrying capacity is also reduced, leading to less oxygen being moved into the tissue cells. The next H we will be discussing is hypovolemia. Hypo meaning low and volemia here referring to circulating blood volume. One common cause of cardiac arrest is hypovolemia, which can develop due to a reduced intravascular volume. Causes of hypovolemia include external blood loss or hemorrhage, severe burns, and gastrointestinal losses. Hypovolemia from blood loss is a leading cause of death in traumatic cardiac arrest. External blood loss is usually obvious, and this is seen in trauma, hematemesis, and hemoptysis. but it may be more challenging to diagnose when it is occult, such as seen in gastrointestinal bleeding or rupture of an aortic aneurysm. The next cause of hypovolemia is severe burns. This happens due to loss of fluid from skin and blood loss. This leads to reduced intravascular circulatory volume, eventually leading to intracellular, which is extravascular volume depletion. Hypovolemia can occur as a result of severe diarrhea and/or vomiting, causing an absolute reduction in plasma volume, and the treatment of hypovolemia here includes rapid infusion of preferably warmed crystalloids and/or blood products while treating the original cause of hypovolemia. The third H is hypothermia. The risk of hypothermia is increased by alcohol or drug ingestion, exhaustion, illness, injury, or neglect, especially when there is a decrease in the level of consciousness. As core temperature decreases, sinus bradycardia tends to give way to atrial fibrillation, followed by ventricular fibrillation, and finally asystole. Arrhythmias other than ventricular fibrillation tend to revert spontaneously as core temperature increases and usually do not require immediate treatment. Next H that we will be talking about is hypo and hyperkalemia, which is low and high potassium levels in the plasma. Electrolyte abnormalities can cause cardiac arrhythmias or cardiac arrest, and life-threatening arrhythmias are associated most commonly with potassium disorder, particularly hyperkalemia. Let's look at hyperkalemia first. The early changes on ECG in hyperkalemia is tall tented T waves, followed by a flattening P waves and widened QRS complexes before turning into sine wave. Hyperkalemia may be caused by kidney diseases. Example is in acute and chronic kidney impairment, diabetic emergencies such as diabetic ketoacidosis and hyperosmolar hyperglycemic state, and as a side effect of certain drugs. Hyperkalemia can be treated by administering sodium bicarbonate or calcium chloride or by performing dialysis. Hypokalemia too can be life-threatening if not corrected fast. You would expect diffuse ST depression and prominent U waves on ECG. The causes of hypokalemia include excessive vomiting or diarrhea or the use of diuretics. Treatment may include a controlled but rapid infusion of potassium. The next H is hydrogen ions or acidosis. Acidosis can be either metabolic or respiratory. Acidosis of any kind is most likely detrimental to the circulation as it causes peripheral vasodilatation, negative inotropy, and impaired oxygen uptake in the lungs. An arterial blood gas is a quick and accurate method to determine if a patient is acidotic. Let's now move on to the 5 T's of cardiorespiratory arrest causes. First T, tension pneumothorax. Tension pneumothorax is defined as hemodynamic compromise in a patient with an expanding intrapleural MS. It is a treatable cause of cardiac arrest and should be excluded during CPR. A tension pneumothorax develops when there is buildup of air in the pleural space. The buildup causes a shift in the mediastinum and venous return to the heart is obstructed, which can lead to cardiac arrest. Tension pneumothorax can occur in a variety of clinical situations including trauma, asthma, and other respiratory diseases, but can also be iatrogenic following invasive procedures. Diagnosis of tension pneumothorax in a patient with cardiac arrest or hemodynamic instability must be based on clinical examination. The symptoms include hemodynamic compromise such as hypotension or cardiac arrest in conjunction with signs of suggestive of pneumothorax, which is preceding respiratory distress, hypoxia, absent unilateral breath sounds on auscultation, and subcutaneous emphysema. And also mediastinal shift, where you see tracheal deviation and jugular venous distension. Treatment of tension pneumothorax is either needle decompression or thoracostomy with chest tube placement. Next is tamponade for cardiac tamponade. Cardiac tamponade occurs when the pericardial sac is filled with fluid under pressure, which leads to compromise of cardiac function and ultimately cardiac arrest. It may be caused by trauma to the chest, such as a gunshot wound, or by inflammation of the pericardium. A thoracotomy or pericardiocentesis is used to treat cardiac arrest associated with suspected traumatic or non-traumatic cardiac tamponade. The next T is pulmonary thrombosis. Cardiac arrest from acute pulmonary embolism is the most serious clinical presentation of venous thromboembolism, in most cases originating from deep vein thrombosis. Common symptoms preceding cardiac arrest are sudden onset dyspnea, pleuritic or substernal chest pain, cough, hemoptysis, syncope, and signs of deep vein thrombosis. Specific treatments for cardiac arrest resulting from pulmonary embolism include administration of fibrinolytics, surgical embolectomy, and percutaneous mechanical thrombectomy. The next T is coronary thrombosis. Coronary heart disease is the most frequent cause of cardiac arrest. Although proper diagnosis of the cause may be difficult in a patient already in cardiac arrest, if the initial rhythm is ventricular fibrillation, it is most likely that the cause is coronary artery disease with an occluded large coronary vessel. Treatment options include immediate coronary angiography followed by primary percutaneous coronary intervention. Finally, T for toxins. Airway obstruction and respiratory arrest secondary to a decreased conscious level is a common cause of death after self-poisoning. Some of the most common drugs involved in an overdose are benzodiazepines, opioids, tricyclic antidepressants, local anesthetics, beta blockers, and calcium channel blockers. This is the ACLS algorithm for cardiac arrest. We will be looking at each level of this algorithm. Let's begin as soon as you have identified a cardiac arrest, where either the patient is pulseless or unconscious with agonal breathing. Start CPR with hard and fast compressions, around 100 to 120 compressions per minute, allowing the chest to completely recoil. Give the patient oxygen and attach a monitor or defibrillator. Make sure to minimize interruptions of chest compressions and avoid excessive ventilation, using a 30 to 2 compression to ventilation ratio if no airway is established. Next, once the monitor is attached to the patient, check if the rhythm is shockable. Shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia. During this rhythm check, the pause in chest compressions should not exceed 10 seconds. If either of these two rhythms are present, deliver shock. Shock the patient with an initial dose of 120 to 200 joules. Once the shock waves are delivered, resume CPR immediately for 2 minutes and establish IV access. Check for pulse and rhythm for no more than 10 seconds every 2 minutes upon completion of CPR. If a non-shockable rhythm is present and there is no pulse, continue the CPR and move to the algorithm for asystole or PEA. Non-shockable rhythms are asystole and PEA. Continue with CPR for 2 minutes. Give the patient a vasopressor such as adrenaline every 3 to 5 minutes and consider advanced airway and capnography, giving one breath every 6 seconds once the advanced airway is in place. If the rhythm has been converted to a shockable rhythm, move to step 5 onwards. This flow is repeated until there is return in spontaneous circulation. Let's recap. Think of all the 5 H and T's as these are potential reversible causes of cardiac arrest. Work up for these causes while resuscitation is going on. Treatment should be administered in concurrently while resuscitation is being done. The 5 H's are hypoxia, hypovolemia, hypothermia, hyperkalemia, and hydrogen ions or acidosis. And the 5 T's are tension pneumothorax, tamponade, venous thrombosis, arterial thrombosis, and finally toxins. We have come to the end of this module. Thank you.